Yes, thank you so much for that warm welcome. To be honest, I am just so excited to be able to present and to talk with you all today. And the topic for today is home care for dementia. And so, in fact, I am embarrassed that I will likely, be talking about things that may not apply to Uganda. And what I would like to do is leave lots of time to hear your thoughts and to have discussions about how home care for dementia, how we can think about it in the unique context of Uganda and the different regions and cultures and languages of the people of Uganda. So I'm going to share my screen. And hopefully you can see this now. These are just a few photos that I found of different types of regions in Uganda and different types of home settings. And so I'm going to jump right in, and please do, interrupt if you have questions in the middle of this presentation, because really I'm here to learn from you as well. And so I will welcome any questions at any time. These are just some of my disclosures in terms of where I've received my funding for my research. To give you a little background, I am a health services researcher at the University of, at Johns Hopkins University in the Department of Psychiatry. And I have had the pleasure of working in a variety of ways with dementia, both doing clinical trials that relate to home-based dementia care and how we can manage the symptoms of dementia at home and support caregivers, as well as serving in an advisory capacity in a number of planning efforts, both in the state of Maryland to create a state Alzheimer's plan, as well as in international communities. So for example, I've helped guide some of the planning that's happening in the country of Greece. And I am very happy to share any knowledge that I have that might be applied to Uganda and managing Alzheimer's disease and related dementias. So today I'm just going to give a brief review of the global and local trends of dementia. I'm going to give a case vignette with an opportunity for us to kind of think about the needs of people living with dementia and family, informal caregivers who are caring for them with a social ecological framework as kind of the way to kind of think about the needs and interventions that could potentially be used to help people. Then I will review some potentially modifiable risk factors that have been coming out in the international literature related to kind of a life course perspective on how we might reduce risk of dementia, especially in middle and low income countries. And then we'll talk a little bit about the care needs and interventions for people with dementia at home. And then I'd really like to leave some time to kind of discuss the unique considerations for dementia care at home in Uganda. So some quick facts, as Professor Wilson alluded to, over 55 million people right now worldwide are estimated to be living with dementia. This number doubles every 20 years and will reach an estimated 139 million in 2050. 60% of these cases right now are estimated to be living in low to middle income countries, and this will rise to about 71% by 2050. Most of these, the vast majority of these individuals are living at home in their local communities. The annual global cost is estimated at 1.3 trillion US dollars, and 40% of this is attributable to informal care. So this is kind of unpaid care that's provided by family members and kin and neighbors and friends. And the greatest of the attribution of the informal non-paid care is actually greatest in the African regions. In terms of prevalence I apologize. I know I'm telling you things that you already know, but I'm just going to lay it out for the context. The prevalence in sub-Saharan Africa varies widely of dementia from 2.3 to 21.6%. And a recent Ugandan study that involved 507 people recently found a rate of severe neurocognitive impairment at 28%, which is higher than some of the other estimates in other areas. We know also that recognizing dementia as a neurocognitive degenerative condition is tough. And only 20 to 50% of ADRDs worldwide are recognized. So in terms of the growth of prevalence of dementia in countries by income, this graph shows that you can see there is a steeper incline in the pink, or I guess orange segment of this graph, which represents low and middle income countries over time, compared to high income countries, which is in the blue. So this is just a visual representation of kind of the growth and where the regions are that more and more people are living with dementia over time. And so each dot here represents 100,000 cases of Alzheimer's. This first map is from 1950. The next map is from 2000. And the next map is based on estimates for 2050. So you can see, if we go back through, where cases are really exploding, and that includes the African continent, as well as India and South America. So some quick facts about dementia based on the literature. So in Uganda, most care is given by family and informal caregivers. This includes spouses, children, and most of these individuals are women. This is a low resource setting. And caregivers over time, according to the literature, are less available due to urbanization. So patients also have receive less care in formal service settings and receive most of their care through informal community networks and families. There are a number of competing health priorities, which include infectious diseases and emerging other non-communicable diseases such as diabetes and heart disease. In sub-Saharan Africa, ADRD has been associated with stigma, shame, depression, anxiety, and that includes in both patients as well as family caregivers. Also increased mortality and dependency on others, neuropsychiatric symptoms or delirium. So that includes agitation, aggression, and hallucinations and delusions. ADRD is also associated with financial stress and social isolation, feelings of family member guilt, perhaps, as well as high familial caregiver reports of burden. And this is especially prevalent in rural communities. So I wanted just to take an opportunity to read a case vignette, which I hope is reflective of the reality of a typical case in a rural community. So I'll just read this. And what I'd like you to do is just think about some of the dementia-related needs that this person might have and some solutions to those needs as I read. So this is about Mary, who is a 69-year-old widowed woman who lives alone in a single room of a house in a rural village. Her children and most of her grandchildren were lost to HIV/AIDS, and those who are left went to live in Kampala for work. Her neighbor has allowed her to stay in the home, although many from the village believe she is a witch and shun her. She enjoys telling stories to the village children she encounters, but no one talks to her much anymore because they believe she's evil because of the color of her eyes. She has severe vision impairment due to cataracts and is having increasingly difficulty with her memory. She is forgetting names and faces. She has an, quote, old woman smell, which she is ashamed of, that isolates her even more. The neighbor's children help her out by fetching water and cooking food for her, and she is provided basic needs by the generosity of this family. She offers help to her neighbor in small tasks around the home, and if she can help in any way, she gets great satisfaction. She has been less able to bathe herself and has been eating poorly recently because of an abscess in her mouth. She is not able to get transportation to a medical clinic and does not have a way to get antibiotics. She feels terribly isolated in her room with no electricity and running water. Sometimes at night, she is frightened and she thinks she sees intruders coming into her room and shadows hovering above her bed. She used to enjoy worshiping on Sunday in the village and has a beautiful singing voice, but no longer goes because it is too far without assistance, and she would not be able to find her way back, and is feared by many in the village. She wants God to take her and tells her neighbor that it doesn't matter where she's buried. So I hope that is a realistic representation of a possible case. And so I just wanted to see if anyone had any, would like to contribute to what sorts of needs Mary has based on that story.
Anybody who has a perspective can put up his or her hand and make a contribution here. Quincy would like to get some voices from the audience.
And in the interest of time, so we can make sure that we have lots of time, I can just call out a few things here. So in terms of her, she has increasing difficulty with her memory. She has a neighbor and community members who may not understand that she has memory problems and that she is obviously not a witch. And so there's kind of an educational component here in terms of aging and stigmatization. She is having problems with her mouth, and that's leading to a poor appetite and probably less weight. And that's because she is not able to get her the abscess in her mouth treated with antibiotics. She's also having some issues with potentially some illusions and maybe delusion or hallucinations at night when she thinks that she is seeing someone in her room. It's hard to tell though, because she has cataracts and she may be misrepresenting what she sees as shadows in her room, or she could be just straight out hallucinating, right? There are some positive things here too. So she gets satisfaction, you know, from helping, from small tasks that she is still able to help. She also enjoys singing, but doesn't have she doesn't have the way to kind of get to church where she enjoys singing. And she also enjoys telling stories, but people are afraid of her because they think that she's a witch. She also seems very socially isolated and depressed. And so some of these things we might, you know, be able to help her by doing things like maybe if there's a way to get her some lighting at night within her bedroom, you know, that could be maybe a battery powered lantern or even a solar powered light that could potentially help her see better at night. Also, if she is kind of engaged in some routine and structure in her daily life where she's given jobs to do, that might also help her mood and help her remain physically or, you know, mentally engaged and bring her joy. So these are just a couple of, also if she's able to get to a doctor to get some antibiotics, we know that the abscess in her mouth could be contributing to extra risk of delirium, for example. So those are just a couple of things that are very, very important that could potentially help her live a better life. And so, so I just wanted to kind of present this like framework called social ecological model for dementia. And the idea is that all these kinds of factors where people are living in their homes, and if we're able to kind of do comprehensive assessments of the different factors that contribute to their health and well-being, that we could potentially come up with very effective ways of maintaining function, maintaining quality of life, and really help people. And so this is just an idea where there's, the physical biology, the lifestyle and factors, the family context, the environmental factors, as well as the community and the policy that are larger. So this is just a way to think about it. So these are some very specific factors that that contribute to outcomes and to progression of cognitive disorders. And so these can be, these can be categorized in terms of that socio-ecological framework that I just presented. But you'll see that there's very, race, gender, education, literacy, food and nutritional security, poverty, safe environment and housing, as well as daily activity support. All of these things are kind of lifestyle and social environmental factors that can very much contribute to people's outcomes, as well as, kind of the more clinical and medical factors that include, attention to other high-risk medical conditions that people might have, sensory impairments like the cataracts that Mary have, as well as mobility issues and other things like incontinence, which is often burdensome to family members, for example. So there's hope in that we are learning more and more about how these kind of multi-level factors may contribute to modifiable risk factors. And so there are non-modifiable risk factors, and these might include genetics, for example, and some demographics that we're not able to change. But what I wanted to show you was that there's an emerging literature from the international literature that shows that across the lifespan, there are certain factors that continuously have significant associations with the risk of developing dementia. And so these include education in early life, hypertension, obesity, and hearing loss in midlife, and then in later life, smoking, depression, physical activity, social isolation, and diabetes. And so if you are able to impact all of these factors across the span of a life, it is estimated that that could contribute to a 35% reduction in risk for developing dementia in later life. And this is the kind of like life course figure that shows those factors and how much each of those factors contribute to the potentially modifiable risk. Now, what's interesting, so I actually worked on this with this set of international researchers in 2017 and then 2020 as part of the Lancet Commission on Dementia Prevention, Treatment, and Care. And what's interesting is that another group led by the Alzheimer's Association recreated that, that type of analysis. And they did it for low and middle income countries. So they focused on Latin America, India, and China. And as you can see from this graph, it's really interesting because of the current factors there, the potentially modifiable risk in some of these areas is even higher. So for example, in Latin America, the estimated potential modifiable risk for developing dementia is 56% if you were able to impact all of those factors. And for India, it's 41%, and for China, it's 40%. Now, to my knowledge, this has not been done for African nations, including Uganda, but that would be really interesting to do. So in terms of care needs and interventions for people who are living at home with dementia and their family caregivers, again, I just want to bring us back to this, because all of the risk factors that we will and interventions that we can consider could be considered kind of on a multi-level in a multi-level framework. So in addition to kind of thinking about risk factors from multiple levels, we also need to think about how different risk factors and needs go over the trajectory or the course of dementia. And so this graph shows people's needs and potential interventions from the time that they have the beginning of cognitive impairment through severe stage of dementia. And what you can see is that the needs, first you have kind of impairments in executive functioning and some memory loss and some IEDL functions of, for example, not being able to get food or to cook for oneself. And then as you get into the more moderate stages, then you have, things like more neuropsychiatric symptoms, you have social isolation, you have basic activities of daily living being impacted. And so I just wanted to share a little bit of the data that we have from the US in Maryland on unmet needs. And again, I'm not presenting this because I think that these needs will be exactly the same in the same prevalence for Uganda, but I think the systematic assessment of needs is the most important message here. And so just to give you a little background, we developed a needs assessment tool that has 43 items that relate to persons living with dementia. And then we have 18 items that relate to needs related to informal family caregivers. And this, in our work, identifying needs in a systematic way serves as the basis for our intervention planning. And so we develop individualized care plans that link best practice-based care to these identified needs. And these are just some examples of needs related to the different domains. And as you see, like a lot of these really, do have to do with kind of the home as the nexus of care. So for example, some of our most common unmet needs are related to home hazards and safety issues. So in Baltimore, we have, for example, infestations is a huge thing. We have bed bugs that are very prevalent in inner city low-income housing. And so that's an example of, some of the home hazards that we have. Also, fall risk management in the home and dangerous objects such as guns and weapons and other types of things, as well as wander risk. And medication management and administration is a huge one in the US because of the high prevalence of polypharmacy. And I don't know how that, if that is an issue in Uganda, I would be interested in hearing. So these are just some more examples of the domains that we rate on this needs assessment tool. And these are related to caregiver needs. So caregiver needs for kind of education about dementia, skills management, so how to manage and how to cope with different types of behaviors like hallucinations and delusions and agitation and aggression, et cetera, how to alleviate their own sense of burden through developing coping skills, as well as developing in a explicit way a backup caregiver kind of network, so that one person is not shouldering all of the burden and strain of caring for a loved one, so that they don't burn out, for example. So this represents from Maryland, data from Maryland in the US, domains of needs where at least one need item was unmet in the domain. And so the blue bars are person living with dementia needs, and the red bars are caregiver needs. And so what you see is home and personal safety is nearly universal in terms of patient needs, and then caregiver memory disorder education, like what's normal, what's not, what to expect in the future, that also was nearly universal. General medical care was 84% had at least one unmet need in that domain. And then 74% of patients had a need for daily living support or meaningful and engaging activities. Over 2/3 had neuropsychiatric symptoms that they had a need within that domain. And then for caregivers, there were 44% had mental health care issues, 43% had needs related to extending or activating additional informal support to help them better engage others to help with the caregiving activities. So we also ask caregivers, so this tool is based on a clinician going to the home and doing a comprehensive assessment that includes like an interview with the person living with dementia, an interview with the caregiver at the home, and then a walkthrough of the home to evaluate it for safety issues. And but this is where we actually ask caregivers, so what are your needs? And they self-reported back to us. And so the most common needs that caregivers expressed was a need for understanding more about the memory disorder and symptoms, understanding what community resources might be available, how to manage dementia-related behaviors, and how to engage people in meaningful activities. Also ways to improve how they self-regulate after being kind of strained for an extended period of time, like so emotional self-regulation. And then also 30% were very interested in ways to get additional support for themselves. So this graph is just a different way of looking at the types of needs. And so this is by mini-mental, so it's by stage of dementia. And it's using a mini-mental cutoff score, which is a cognitive test to delineate mild, moderate, and severe dementias. And these are the needs that are for related to kind of disease management and functional support. And what you generally see is that, home environmental hazards were some of the largest needs, as we've already shown. But over time, it seems like caregivers were able to kind of, that either remains the same or goes slightly down. In terms of supervision adequacy, for example, you see in the mid stages, it actually goes up. And then for ADL support, it goes up as well as the disease progresses. So wander risk management is another one where you see it less frequently in the mild stages and then more frequently in the moderate stages. So these are needs related to quality of life and social support. And here, what I wanted to point out was that the intensity of care goes up. And so for example, the backup caregiver support goes up over the course of dementia, so between mild, moderate, and severe. Also, symptoms, neuropsychiatric symptoms such as agitation, those go up, and caregiver social isolation tends to go up in prevalence of unmet need over time. In terms of emotional distress, that also goes up in the moderate stages and then goes back down. And then finally, I wanted to provide a look at what happens to caregiver burden and caregiver depression. And it's exactly what you would anticipate. As the stage of illness gets more severe, the neuropsychiatric symptoms become more frequent. The distress the caregiver distress based on the behaviors goes up slightly, but not tremendously. The Zaret burden, which is subjective burden rating, goes up a bit. But what really goes up is the hours spent per week of caregiving. And so you can see it, an average of 75 hours goes up to 105 hours in the 3 stages. And then the hours spent helping the person per week also goes up very dramatically. So I think this is definitely something that likely will apply to any population of people with dementia, just based on the symptoms and what we know about the neurodegeneration that happens. So from this study in Maryland, we also see that there are racial disparities based on if you look at people who identify as white versus people who identify as Black, and the with people who are Black having more unmet care needs at baseline, and particularly more unmet needs related to meaningful daily activities, legal issues and advanced care planning, and caregiver legal concerns, and mental health and daily living. So in terms of generally what we know about effective management, so we know these needs are prevalent, and what do we know about how we can help that? So we do know that if we're able to manage comorbidities and address medical complications, we can potentially prevent delirium. And we also know that if we make home accommodations, we could potentially, set up an environment where we prevent falls, we prevent wandering, we can prevent and maintain motor mobility and strength. We also know that if we simplify medications and people don't have polypharmacy, for example, that we can help in that way, and we can also help in terms of making sure people are taking their medications correctly with medication management strategies. We also have a number of behavioral interventions, protocols that are effective in treating some of the neuropsychiatric symptoms. However, learning those protocols does place additional burden on already burdened family members, because it's mostly family members who need to be trained in how to deal with behaviors. We also know that providing people with dementia psychosocial support and activities and daily activity structure helps in terms of their quality of life and delaying need to move out of the home, and as well as addressing home safety issues and hazards. We also have strong evidence in the literature that suggests there are specific programs that are effective at helping caregivers develop better communication skills, for example, as well as peer support and respite opportunities to give them a break. So these are some of the effective management approaches. However, these might not all be feasible, obviously, in low resource settings. So in terms of outcomes, one of the most important things that we have to ask ourselves is what are the outcomes that we are striving for, and so many people take kind of a palliative care approach to dementia in terms of how to assess outcomes and whether we're meeting goals of care. And so in palliative care, really, over the course of dementia, you first, kind of are addressing the prolongation of life, so reducing mortality. And then you really are focusing on maintenance of function. And then in the moderate and severe stages, really maximization of comfort and quality of life are things that you might be striving for. So just to kind of reflect on our case vignette, Mary, who was the 69-year-old woman who was mostly blind, who was living in the village. I just wanted to kind of put it out there. What outcomes are we hoping for Mary to have? What would be a good outcome for that case? Would it be quality of life? Would it be prolongation of her life? And if you have any specific ideas, like jump right in. But it's just kind of a rhetorical question in some ways. And then we also could ask ourselves, what outcomes are we striving for Mary's neighbor family? So the neighbor who took Mary in because she didn't have anyone else to provide a home or care for her. How could we, what are the outcomes that we would try and target to help her neighbor and reduce the burden that she might be feeling? And what about the community, the village as a whole? What outcomes would we like for them? Would we like to be able to teach them that when people's eyes turn cloudy because of cataracts, it's not because people are a witch or they're evil, it's a medical condition. Or if someone is behaving in a strange way and it's the result of neuropsychiatric symptoms related to dementia, that is a disease process versus a spirit or something like that. So, kind of community education might be an outcome in reducing stigma. So these are just a couple of, kind of desirable outcomes from, that typically are examined when we develop interventions that address the symptoms and management of dementia. And then again, I just wanted to come back to kind of just thinking about this issue in the context of all of these different levels. And you could actually build outcomes that would be equal to these. And then we only have 8 minutes left, but these are the questions that I had, for you, like after this presentation, because like I said, I recognize that this information that I've provided is likely not directly translatable to the issues that you're seeing in your home country. And so I would love to hear your thoughts on what are some of the most common needs that Ugandans may have who are living with dementia, and what are the most common needs of people who are caring for them. And then also, what are some of the unique characteristics of the cultural or social or physical environment that could either impede care, which is, obviously, access to health service, formal health services, things like that may be barriers, but there could also be facilitators as well. And then what are the outcomes that matter? What types of interventions might be feasible? And, what lessons can be learned from other public health crises that related to kind of home care and community care, such as, any learnings from how HIV/AIDS has been dealt with, or other types of diseases. So I'll just open it up for discussion. And I really just want to learn from you all what your thoughts are on these questions. And don't be shy.
Thank you very, very, very much, Dr. Quincy Samus, for this wonderful presentation about dementia, your perspectives and the data that you've shown us, and the different thinking thoughts that are going on around how to organize care, and the example that you brought before us. So, ladies and gentlemen in the room, Dr. Quincy has posed some questions for us. If you want to make a contribution, please go ahead and go for it. I see one hand up from HEPI University College of Health Sciences. Please go ahead and unmute yourself and make your contribution.
Thank you. Thank you very much for that wonderful presentation. I must say that from what you presented, the needs of the patients here and the needs of the caregivers seem to be the same. And this is my personal observation. I feel that I was really impressed by the fact that much as we focus on the patient and we want a good quality of life, and simple things like improving the lighting and all that come a long way. It's not only the dementia, but the other things around where they live and the protection are very important. But the caregiver should also be given attention. And I'm not sure whether this is done. And they need to be educated about the disease, but also the time they put in is a lot. So I believe that the results you have may be applicable to what we need here to support not only the patient, but also the people around. And maybe what I see is in many of our families, we stay with these dementia patients in our homes. And because of our families being large and also the patients with us, probably if we can educate the families so that we have more support for the people taking care of the persons with dementia. I think I'll stop here for the time.
Thank you so much, Sarah. That was really amazing. And that was actually one of the things that that struck me when I was trying to educate myself about the general demographics of Uganda, was that the average number of children was 6. And so that does imply very large families, and maybe there's opportunities to more systematically kind of create purposeful networks, caregiving networks, so that one person is not shouldering the burden for elder care. I don't know, I'm just thinking out loud. I think Diana, did you have your hand up? Would you?
Yes, I do. I appreciate the presentation. My mom is 86 years old and she has dementia. We have gone through all these stages which you have talked about. And the good thing, we are many. So we try to give the care as much as we can, though sometimes we don't know what to do. We think she's wandering, but at least she can still understand most of the things, though she forgets our names. When she sees us, she knows we are her children. But the wandering bit has been worrying us so much because she was very active. She doesn't want to sit in one place. She will be worried about her garden. She worries about the workers. That's really how worries her. And when she's weak, that's when she will be down. But the moment she has her energy, she will walk out and go to the garden. So we worry about her crossing the road and other things, but care is a bit difficult, especially when it comes to people who are looking after her. You know, they may not give all the attention that she needs because you follow her, she gets upset. Why are you following me? Why are you spying on me? So basically, those are the challenges we get, but we give her medication because she has some issues of pressure, which we manage. We treat her with some of the memory boosting drugs. We really do our best. And sometimes she's fine, sometimes she has forgotten us, sometimes she remembers, but now we know. And this presentation has been really something good for me. Thank you so much.
Well, Diana, it sounds like you are doing an absolutely fantastic job caring for your mother. And wow, those are exactly the issues that we see too. In fact, this weekend, I'm going to get my grandmother from my uncle who has been caring for her to give him a break. So we're going to have a weekend away. So we're sharing the caregiving here too. Dennis, did you want to make a comment?
Yeah, thank you very much, Professor Samus. Actually, I am trying to register my PhD here with Makerere, and my topic is on quality of care in the home for dementia, for people suffering from dementia. One of the papers that actually got me interested in this is what you wrote and colleagues about moving the nexus of care to the homes of people with dementia for various reasons that you put in that paper. However, in Uganda, or like in most low and middle income countries, we have not been able to know exactly what is the kind of care that these informal people are providing in their homes. And when I looked at your presentation, you talked about needs and burden. And then I wanted to think through how we can look at the needs and the burdens and then match that to the quality of care, or meeting those needs and finding the quality of care that can fit most of these people in their home. So my question really is around what kind of framework, or do you have to involve all this and go in and measure the needs and also the burden and see how most of those needs, are they being met or not met, and how does it relate to quality of care? Thank you.
Yeah, thank you, Dennis, for that. And you know, that paper that you're talking about was one of, like, I'm so proud of that paper because it really is what I believe is that the home is the nexus of care. And in terms of the assessment of needs, so I had the pleasure of working with Sarah and others on a grant application recently that was submitted to NIH to do a collaborative examination in a systematic way of the needs in Uganda for people who are living with dementia and caregivers. And so I think you're absolutely right. And so we don't know if it's funded yet or not, but I think you're absolutely right in terms of a first step is to document what needs exist and which ones are the priority needs, and then to assess the community resources and informal, informal support networks that might exist, and then to try and link feasible and practical solutions to the most common and most impactful needs that we find. And so it's kind of like a stepwise process to kind of to solve the problem. But I think that you all, and I would love to talk more with you, Dennis, about your research. But I think the process is underway, and it seems like some of your colleagues are, working on this actively to try and get a benchmark for needs.
Do we have any other question in the room, or a contribution, or a comment?
I think Rita.
Yes, Rita.
Yeah. Thank you so much for the presentation. I joined in a bit late because I saw the link late, but the reason as to why I was interested is because I'm trying to write up a PhD concept. My name is Rita Nasanga, and I'm a radiologist and lecturer at Makerere University. So I got interested because my topic is going to be about MRI findings in patients with dementia that are presenting at the neurology clinics in Kampala, as well as, some other cohorts. So that is why I was interested. I don't know if Diane, you've heard about any significance of imaging in dementia, but yes, that's what I set out to study. And I will also be looking at, the imaging protocols and the perceptions of the physicians and the radiologists as they work on these patients with dementia. Thank you so much.
Thank you, Rita. So imaging is, in biomarkers, radiological biomarkers and things, is a great topic. And I personally am not, I don't have expertise in that, but what I could do, if you email me, I could connect you with some folks at Hopkins that are, that do a lot of research on that, if that would be helpful to you.
Yes, thank you. So, okay, so I think let me get the email from here. Thank you so much.
Thank you, colleagues. Quincy, do you have space for one or two more?
Oh, yes, please. Yes.
There is Joy.
Yes, sorry.
Joy.
Hello. My name is Joy Cheyune. I'm a doctor. I work in England and just got this link just in my lunch break. So I've just joined. Yeah, this is really interesting. Thinking of our setup in Uganda and support for families. It's really, I think, a big issue. And I was looking at the nurses, where nurses and the psychiatry side of things, mental health nursing, because I know there are few psychiatrists to assess and to make the diagnosis of dementia. However, could other health workers be involved in at least making the diagnosis and educating, particularly nurses? I think there are more nurses than the specialist psychiatrists in Uganda. Yeah, that's my input. Sorry, my camera is not on. I can't put it on at the moment.
No, that is a great point. And I don't know if you were here when I was talking about this collaborative grant that we partnered with Makerere to do. But one of the a major feature of it is to test and identify tools to detect cognitive impairment that could be used that would not require kind of a standard language, for example, because I understand that there are a number of languages that are spoken in Uganda. And so it would be kind of a tool that would be kind of universally appropriate, in that is one of the very important. Detection obviously is very important, and I agree with you that in a structured way, certainly nurses could be utilized to increase the rate of detection in education.
The new hand, I thought we are coming to the end, Chair, but before you close, I wanted to be given an opportunity to say something.
Go ahead.
Okay, I would like to, I can't put my camera on, but I'd like to thank Quincy for this lecture, but also your colleagues from Hopkins who have been giving us such educative lectures throughout the last two months or so. Today, for some reason, I think many people didn't know that this lecture was happening, and yet it's very, very, very important. And I think it touches on many of us who may not be psychiatrists, but who are general doctors and other health workers.
I think we might have lost your your voice there.
I don't know what has happened, but I can hear you. I can hear you, but I don't know what has happened.
Yeah, we can hear you now.
Okay, so just to thank you and your colleagues for this, and to say that today I don't know what happened. I think many people did miss the announcement, and yet dementia touches on many of us, even if we don't treat patients. But as Joy said, many of us doctors and other health workers need to be aware of what is happening because of the number of psychiatrists being small. So thank you, but also to thank the HEPI project funded by NIH, which has given us this opportunity. I hope that we shall go through with what we put up, but also there are many needs. I'm very glad that there are 2 people here who are trying to do their PhDs in the area. So I think this is the right time for us to address such unmet needs in our society as we move towards having a healthy population. Thank you.
Thank you, Sarah. That was wonderful. And I'm going to let all of my colleagues know, that how much it's been appreciated. And I know that honestly, for me, like I have been looking forward to this presentation for quite some time, because I really look forward, and I hope that we're going to be working together, in the future on this kind of problem. And so really appreciate your attention.
Yeah, so thank you very much, colleague. Thank you for the wonderful presentation, Professor Quincy Samus, for the way you took us through the work that you have been doing, and it was very revealing.